And now we're coming to the interesting part of the Q&A. So what we're going to do, I'm going to try and multitask, which is not my strength, but I will try and multitask. And I will very glad that there's someone who's going to be translating this into Hebrew. And I'm glad it's not up to me. So what we're going to do is we're going to put some of the questions that have been sent in to our panel. I think the panel is made up of people that I think some of whom you've heard speak, and we actually have a special guest. So we have Horacio, and we have Alejandra, and Patricio, who you've already heard speak, and of course Francis and Sue, and Bat, and we have Kaya and Zenith, and we also have a special addition. A guest is Dr. Leela Raju, who is an ophthalmologist who's working on the treatment of cornea at NYU Langone, and she's going to be able to hopefully answer any questions we have about treatment of eyes. So I'm going to start with my first question, which is to Sue. Sue, your question is, and this is straight to the point, what has to happen to get PTC 680 into the clinic, and when?
Good. Thank you, Adrian. Can everyone hear me okay? And see me? I hope.
Yes,
okay.
Yes, we hear you.
Okay, good. Okay, great. So once you get a drug to a certain point, we've already done a lot of testing on this drug, but you must test a drug and do toxicology studies, or what I'll refer to as safety studies, using a drug that is manufactured in a way that it's pure enough to give to humans. So we have to do manufacturing of this drug, and then we have a series of toxicology studies or safety studies that have to be done. The issue is that this costs us about between $1.5 and $2 million to do all these tests. It might sound ridiculously high, which I think it does too. However, there are many tests that need to be done, and they have to be done in different animal models. And from the time we get the funding, which I'm hoping to get through the National Institutes of Health, through NIH, it should be approximately 1 to 1.5 years. And then if all turns out well, which we're hopeful for given our preliminary testing, then we should be able to initiate clinical trials in patients.
Okay, thank you very much, Sue. I'm now going to go over to Francis. So my question to Francis is probably a similar kind of question, although I understand genetic therapy is very exciting and it's advanced, but when do you think we'll be able to get this, at least to start thinking about the preclinical development and hopefully into the clinic with gene therapy?
Well, thanks for the question. The first step was showing proof of concept in mice, and we're still trying to test sort of the see what are the maximal benefits we can get in the mice. So we're still optimizing the approach and the vector. But in addition, the key transition is to see if is making a vector that can then be used in humans. And so that's what we're working on now. The point is, once the vector's made, and this is the work that's been funded by the Dysautonomia Foundation, once the vector's been made, we have to test that it expresses well in human cell lines and in the mice. That should happen by the end of the year. We should know those results. If that looks promising, then, like Sue, we will need some funding to then do some of the toxicology work to make sure it's safe. So typically what you do is you test it in other organisms like non-human primates typically, or other higher order mammals, and to see if it's effective in the eyes of those mammals. So that's going to require some funding, and then funding to then, initiate a trial. Once the vector's made, again, our focus has been on the retina, but we could also develop protocols to test it systemically. but we are not as far along as Sue, but we hope to get there.
Okay. I'm sorry I put you on the spot, but people are asking this question, so I think it was,
No, no,
an
okay,
excellent
totally
answer.
understandable.
Well done. And now I'm going to go straight to Horacio, who also said that he thought that there could be the oligonucleotide potentially even by the end of the year. So can you give us some more details on that, Horacio?
Sure. Thanks, Adrian, for the. Well, this has been an exciting ride with the ASOs. I mentioned that they were used in spinal muscular atrophy successfully, together with, interestingly, spinal muscular atrophy has ASO, also has a genetic therapy, and has a small molecule. So the three of them are being used together in patients. So the hope is perhaps to do the same on FD. So let me go to the ASO. Adrian designed one that was published in 2018, and then in Lorem, this foundation that was created by the manufacturers of the drug, and they have enough funding, committed to do the type of toxicology studies and optimizing for human use that Sue and Francis mentioned for the other alternatives. So the whole team is meeting with this foundation every 2 weeks. We've been meeting since the beginning of the year. We have the protocol almost finalized, and we will be requiring from the FDA authorization to treat one patient, which is what NLOREM once agreed to do the toxicology for humans and allow us to start with one patient. And although it seems to be within a year, I learned not to promise exact times, but is actively being worked on. And of course, it's not as simple as taking a pill by mouth, so one doesn't preclude the other approach, but we hope that this perhaps will be the earliest that will go into clinical trial. Hopefully, Adrian, hopefully.
Okay, that's so encouraging and so exciting. We hopefully could be talking about clinical, which is beginning or starting to begin already at next FD Day. Because I know we've been, it was Sue who said nearly 30 years, and this hopefully could be the year when we really are starting to begin. We're not promising anything, and it's not just up to us, but there really is something out there in 3 different fronts which we're trying to work and to push forward. So that really is very exciting. Just a word of warning. I understand Sue may have to leave early, so if anyone has a question specifically to Sue, please post it in the Q&A now. I'm going to go over to Leela, and I would ask you, please, to give us a little bit of your insight on the treatment of the cornea in FD, and particularly how you help people who perhaps have repeat abrasions.
Sure. Can you hear me okay?
Fine, yes.
Okay. So I think, I was just talking with FD team actually on Friday about, I think the most important thing is to always think of it in terms of prevention. Even if there is not something that you're actively treating at the moment regarding it, specifically an abrasion, it's all about how do you avoid it in the first place. So, I think most FD patients are already using artificial tears on a regular basis, artificial tear gels at night. It doesn't always have to be an antibiotic cream or ointment. I think just the moisture itself, something that stays around on the eye better overnight, which the artificial tears don't do, just because it evaporates over time, and the gels do much better. I think moisture chambers, which can be bought online, either a single moisture chamber that looks like a clear pirate patch that the patient, anyone can see through, or even goggles work really well, because if you're doing something like CPAP, that might be blowing air into the eyes overnight. That's also going to be part of the problem. And then during the day, I think scleral lenses have made a huge difference in a lot of the FD patients I've seen. So it doesn't have to necessarily be a specific kind of scleral lens. I think there's a lot of good options. There is a learning curve, obviously, that comes with those, and knowing how to take care of them. But I think that has made a really great strides in being able to avoid those abrasions in the first place.
Thank you, Leila. I know from our own experience, so much of what you say is true, and we really, there's, eyes is something all through our lives. We're worrying about other things, but you never take your eyes off your eyes. Really have to make sure that we keep on top of managing our eyes. Okay, now I'm going to go over to Alejandra, and I wanted to ask you a bit more about what you said about precision medicine, and also maybe you could give us a bit more insight in what are the more common approaches that you have in the center. What do people consult you on?
Thanks.
Yeah, we see you now.
Before medicine, which is a different vision of medicine, which means that we have to be very hands-on the predictive and the preventive measurements. But also, for me, the most important thing is it's personalized and participative, which means that we need to understand what the patient and the caregivers want before we can actually provide a full plan. We can make directions, recommendations, but the idea is to have everybody involved before we do the actual plan. And it's very far away from traditional medicine, where it was a little bit paternalistic or maternalistic, where the doctors said, and that was the last word. So I think that's the plan. That's my approach to patients. And I don't remember the second question. What was?
The common consult. What do people come to you with?
Infections. I think that's the most common cause of consultations that we're having. Of course, we don't treat them lightly, because we know that infections can actually spread or be worse than what we think, because people are not complaining of. So every single, even little scar, we will get into the depth of how far, how difficult, how effective, what should we do to prevent further complications of that. We are a little bit more liberalized with antibiotics than in other special consults, I think, because these patients are so fragile that I do not doubt of being aggressive. And the other thing that I have in mind, it's very, very complicated for me, and I think for the most people to understand, is the bronchoaspiration. I think it's one of the main things that we have to target right now, because I've been dealing with a lot of that.
Okay, if we're talking to you, actually someone asked, how do you increase low sodium levels?
Depending on why. I mean, it's not easy, it's not an easy task, and also it's dangerous to do it really fast. So you have to be very aware of how low and how much time the patient has had that low sodium. So that's something that we should go and do it directly, not the patient. However, what we find is that patients that are in crisis, they usually get low sodium, and we recommend to have half a teaspoon of sodium in the feeding while they are on crisis, because we know that they will end the crisis with a little less sodium than what they have with the hyponatremia.
Okay, thank you. That was a quick question about hyponatremia. Okay, over to Bart now. Someone's asked a very good question. How do oxygen concentrators work, and do they recycle air? So is it safe to go on a plane when people have COVID and use an oxygen concentrator? But
hi, that's a very clever question. Concentrator works with a compressor that produces heat, and then the air that it comes from the air that we breathe goes to two filters that separates the nitrogen and the oxygen, and that is why that's an oxygen concentrator. And then the oxygen that from the ambient is around 21%, arrives to 95% with the oxygen concentrator. But during this procedure, using the heat and the filters, most of the COVID do not survive. So oxygen concentrator cannot concentrate the virus, so it's not dangerous. However, it's not a closed circuit, because it's not like a BiPAP that closes the whole mouth and nose. So you can still get the virus from the ambient, but not from the concentrator itself.
Ah, good. I'm very glad to hear that. Thank you. And I'm very impressed with your explanation. Thank you very much. I'm going to go over to Patricia now. I'm jumping over back to America. People are asking about the use of medical marijuana, or maybe even one specific derivative, cannabinol. Do you have any experience of this in dysautonomia?
Yes, it's a very good question. And we know that almost all medications that we take nowadays derived from some natural compound. Taking a natural compound by itself is a way to try to get a dose of that specific compound. So with marijuana itself, we know that we have had experience in patients with FD with a specific synthetic compound, which is dronabinol, that can help alleviate nausea in patients with different neurological disorders. Recommending smoking the marijuana itself, that can be a complicated issue. But can talk more about that because it can have pulmonary complications as well. But dronabinol is a compound that is approved by the FDA. It's available and can help alleviate nausea in patients with FD.
Okay, Bat, do you want to add anything to Patricia's answer, our experience in Israel with this?
In Israel, we have 3 patients that that had worsening in their morning nausea and started losing weight, and they were doing really bad. And they started using the CBD and the THC in a relationship of 1-to-1 with vapors, not actually smoking them, but using. First, they started with oils. It didn't really help, but since they're doing the vapor, most of them are doing much better. They gain weight, and it's not a trial, but it's just an experience of 3 patients that are doing really well with that with the cannabinoid.
That's really interesting. That's something maybe we need to explore. Thank you very much for your answer. I'm going to go to Zenith now about FD, and if you can't answer, please feel free to ask your colleagues. So someone's asking us, can I attend an indoor social gathering if I wear a well-fitting KN95 mask? Or how safe am I when others are not? And I guess I could throw in the question.
Hi, thank you so much for this question. And Zoe, I love your Instagram. I love all of the posts that you put over. I'm sorry, I didn't hear the end of that question.
No, go ahead. So we have a delay between us, so we run over a little. I apologize. So it was a question about the mask and safety, and also maybe if you could comment on the second booster.
Absolutely. So first of all, thank you so much, Zoe, for your question, and also for all of your very informative posts about advocating for people with disabilities. I think it's really, really vital what you're doing in the community. And so to answer your question, attending any indoor social gathering carries some element of a risk. There are different levels of masks. So we have the cloth masks, which reduce your chances of testing positive of COVID by 56%. The surgical mask, which reduces your chances of testing positive for COVID by 66%. And then the KN95 mask, which reduces your chances of testing positive by 83%. That being said, a mask that's worn on your chin is not an effective way to wear it, and that is a 0% chance of reducing it. So, we really advise people to wear your mask, wear it properly. If you have any specific things that in terms of the fitting, we want to make sure that it covers the bridge of your nose. It's not soggy, it's not wet, it's not something that, is old and you've worn it multiple times and can sometimes cause some just wear and tear with it. So, replace your masks frequently, purchase them, and whenever you're going out in public, in any place that's outside of just your family, if you're in a public setting, definitely wear a KN95. Also, you know, I think in terms of the second booster shot, we're advising all FD patients to be receiving it at least 6 months after you received your first booster shot. And, you know, like I said during my presentation, we've had success with all patients tolerating it. But the most important thing that we can't stress enough is use around the clock pyretics, antipyretics, to make sure that, you know, you're reducing your chances of having reactions. Everyone in the general population, you know, reports some more fatigue or reports some more fevers for, you know, that 24 to 48 hour period after they get the vaccination. And for anyone with FD, we know that, you know, having a fever can cause some autonomic crisis. So, you know, even if that means waking up in the middle of the night and, you know, having your medications at 2 a.m., make sure that you are receiving it if it's Tylenol in the absence of any liver disease. And if you don't have kidney disease, you can use ibuprofen. But yes, get the vaccines, get vaccinated, have your whole families vaccinated. And one other tip, Zoe, that I could add is if you know you're going to be in a setting in which, you know, people may not be wearing masks, but you know who those people are, ask them to do a home antigen test prior to hanging out with you. I think, you know, there's a lot of asymptomatic COVID that's going around. We're in our 5th wave right now again in New York with the BA2 variant. So, you know, we really just want to ensure that everyone is staying safe and as safe as possible while still, you know, doing the things that you love. Thank you so much.
Very, very, very much for your answer. I actually wanted to ask Leela a question. I know that she may have to leave soon as well. So Leela, we were asked about if you were aware of other eye treatments which potentially could be relevant to FD patients. And we were also asked a question about recommendations for pediatric moisture chambers. So if there's anything out there that you want to comment on, we'd be happy to hear.
Sure. Interesting. I think Amazon has the best options for all sizes of moisture chambers. It's amazing what you can get on that website. So I would try there first. It's probably the easiest in most countries since they do have such a broad presence across the globe. And then, yeah, I think there's some very interesting new treatments for, well, some of them are not so new. So serum tears, which can actually be made from a patient's own blood, I think can do a remarkable job in helping protect the corneal surface, in addition to the artificial tears that I mentioned before. There is also, and we were talking about this with the team just this week, there's a new medication called Tyrvaya. It is varenicline. So interestingly, it is a smoking cessation medication orally in the US, but they have made it into a spray, a nasal spray. So one, it's nice that it's a different method of delivering it. And also because it goes through the nose, and it may be using a totally different pathway to help stimulate tear production. And it's not counting on the whole feedback loop. The reason we make tears is because our eye is telling our brain we're not making enough tears. So if those nerves that are supposed to be telling your brain it's dry aren't working, then you got to find a way to bypass it. So either we do that by putting in the artificial tears, or perhaps this spray may have some benefit. Once again, it is a newer medication. I have not specifically asked FD patients to use it yet. So, but it may have a couple different benefits that, you know, it's a nice change of pace. Then of course, there's a bunch of other medications that we use when there is already an abrasion that's not healing. Serum tears is one of them. And there are other medications, or one is called Senergermin. It's a generic or the compound is Senergermin. It's actually a growth factor that helps reconstitute some of those nerves in the cornea. That tends to be more when someone already has an abrasion and we're trying to get it to heal up faster. And of course, there's a number of procedures, but like I said, the biggest thing is always, how can we avoid having to do a procedure? I think the eye does best when we've avoided that issue in the first place.
Yeah. Are there examples of tarosophy being performed in the
absolutely.
US?
I think it's an underutilized procedure for to avoid either abrasions or to help heal. obviously not ideal for patients. I know they don't necessarily like having their eyelids slightly closed, but in the grand scheme of things, if it actually avoids the abrasion from recurring over and over again, because that's when you also get scarring in the cornea, and that, you know, opens a whole other list of problems. So if doing a tarsorrhaphy for either a short period of time or a little bit longer helps avoid that or help one heal without scarring, I still think it should be definitely be more frequently considered than we often do.
Thank you very much. That was a very, very, very thorough answer.
Absolutely.
I'm going to go over to Alejandra now, and I've got a question for you. Is there a connection between homeostasis and FD? And perhaps there's one of the other physicians on the line may want to answer the question. Homeostasis and dysautonomia, is there any relationship?
Homeostasis, it's such a difficult question for the community now, because it implies that we have everything on balance. And every patient, what they have exactly is that they don't receive the information either accurate or on time. So they are constantly resetting the set points to get whatever they can understand and be more or less balanced in terms of homeostasis. So I think that as they are asking me the most complex thing that we are doing now, which is try to get them into the best position or the normal position, but baseline for these patients is different between each other. So we have to understand which is the baseline and where do we want to target.
Okay, thank you. No, it's a very complicated question, but it's actually quite a good question. I'm going to ask Patricio now. Someone's asked us, how effective is meditation in dealing with crisis?
Oh, so that's a good question, and it's very complex. But if I can break it down simply, it depends on two factors. One is depending on how severe your crisis is, how severe it's getting, and the other one is how good you are at meditation. But we do have patients that, like I mentioned before, have been very successful in completely aborting crisis just by meditation alone. So it's completely a technique that it's worth trying out.
Okay. Thank you. I have a question. Actually, I'm going to ask, it's a question that's come out of Israel, a question about phosphatidylserine, which I know that there was some research done some years ago. So maybe this is a question I will ask maybe Bat, if you're familiar. Are you familiar with this treatment? And is this something which has been shown to be effective? I'm curious to know, maybe either in Israel or in the US, if that's something which people are still trying.
For a long period, most of the patients in Israel were treated with high doses of phosphatidylserine. And from the OCTs that were done, I don't think that we saw any clinical effect.
Okay.
So most of them are not on this medication anymore.
Thank you very much for your answer. I'm going to go back to Francis with a question. It was something about, I hope it's okay that we're going between clinical and research, but I just want to follow up on something which was raised earlier on with regard to basic understanding in dysautonomia. Francis, why do neurons die in dysautonomia? What's the basic cause of that? Why does this ELP1 sort of mutation make neurons die?
So it's a good question, and we obviously don't know everything because turns out to be a really, really important protein in the cell. But one of its key functions is it associates with 5 other proteins to form a complex, and the complex is called the elongator complex. And that complex is essential for the translation of many different messenger RNAs in the cell. So it acts very upstream to regulate the expression of many downstream proteins. So if you analyze all the proteins in a cell, if you have reduced levels of ELP1, you find that many protein levels are altered. So we're, so we're affecting many different activities inside the cell, but one of the key functions we are interfering with if you have reduced ELP1 is energy, as I said before. So the big energy producer in the cell is the mitochondria, and we find that mitochondria aren't functioning normally. And if the mitochondria aren't functioning normally, the cell doesn't have enough energy to do all its normal functions. So the neuron, but what's fascinating in FD is that some neurons are more dependent on ELP1 than other neurons. So that's why, so for example, the pain and temperature sensing neurons, they seem to really need a lot of ELP1 in utero. But the neurons that mediate the balance and the ataxia, those neurons don't need ELP1 in utero, but they need it as they get older, as patients age, their balance starts to take a hit. So different cells are more resilient than other cells, which is good news. I think I'll stop there.
Up to this point, I understood you, but I think you probably better stop.
It gets complicated, but energy is a big deal. Having enough energy.
Okay. I'm going to ask Horacio another question. I'm going to go back to the ASO discussion. When we spoke about it last year, we were talking about injection into the eye. Has that changed? Are we talking now about a different route of administration? Can you want to give us some more background on that?
Yes, you're absolutely right, Adrian. The way we were able to get into the program, I mean, maybe I'm telling you too many details, but the way we were able to get NLOREM to choose FD, despite the fact that their focus is on diseases that are more rare, that's quite a paradox, right? We have 310 patients, and of course, this is a very rare disease, but NLOREM works with ultra rare. So some of the patients are only 2 or 3 patients only for this program. So what we had convinced them was that the problem in the eye occurs only in young people. So then after that, the damage already occurs, and we were trying to only treat very young patients initially. Because of somewhat of a serendipity, because this requires testing in primates, meaning in non-human primates, meaning monkeys, and it's impossible to get monkeys now. It takes 2 years, right? Again, too many details, but because of that, they agreed to do it intrathecal, because to authorize intrathecal, they can do the toxicology only in mice and perhaps in dogs, but it's not necessary to do it in monkeys or non-human primates. So because of that regulatory issue is that they agree to do it intrathecal instead of in the vitreal, inside the eye.
Okay.
So we were quite happy with that. We think it's easier. But also the amount they have to produce is much higher. It may not get to the retina with the same concentration, Adrian, but it does get to all the dorsal root ganglia and the rest of the brain. So we think that our target now is broader, and in addition to measuring vision, we are going to measure ability to walk. We think that this may also prevent the progressive worsening of balance.
That's really it. You're talking about a potential upside and benefit from the drug if it's given, if you like, systemically or over the whole body in way beyond just the eye.
Correct.
So that's really is something, although it's at a greater cost to those who are going to fund development, which is good news for us, I guess.
Absolutely.
That really is good news.
Yes.
Okay. We've got a couple of minutes left. I've actually a question for Kaya. was about, are there any innovations in perioperative management? In other words, preparing people for surgeries and operations.
Hi, sorry. So Kai just stepped away because she's taking care of a patient who's in the ICU right now. So I'm back. So in terms of perioperative management, you know, it's truly a case-by-case situation. We want everyone to call us before any procedures so we can discuss their cases specifically. We don't have a specific broad general recommendation. We really do care about IV hydration or hydration status of the patient to ensure their hemodynamic stability when they are in the OR, especially for procedures that are going to be lasting for more than 2 hours. But like I said, please give us a call if you are going for, you know, outpatient procedure that's going to be, you know, done in a dental office, or something that's going to be, you know, much more serious and that's going to be requiring intubation or anesthesia management.
Okay, thank you very much. A question for Francis. Someone's posted three very good questions, but quite long questions. So I'm going to go over the first one. Something called the Resilience Project of Dr. Stephen Friend, or of Dr. Eric Stadt. There's an article about genetic data and understanding whether if you carry your genetic makeup can help understand the progress or the treatment of your disease. Is this something you're familiar with, Francis, or is anyone on our panel familiar with?
I'm not familiar with it. So you're talking about resiliency at a molecular
No, Resilience is the name
level?
of the project. It's a specific project we were asked about if we're familiar with.
I'm not, no.
Okay, thank you. I'm just looking through the questions. Are there any other questions that I've missed or that we want to answer? I'm actually, as far as I think, we're now at 45 minutes or 40 minutes. So I guess it's time now, if I don't have any more questions. And by the way, if your question wasn't answered, I apologize. And we will try to address any other questions online afterwards, and I'll make sure that we try to do that. I want to thank everyone on our panel, including those unfortunately who've had to leave already. I think it was fascinating today to share the information, not just about the research, but also about what's going on clinically. And it's really been very interesting. And thank you everyone for listening.